What is going on? It's Medicosis Perfectionalis. This is the 5th video in my general pharmacology series. It's time to talk about elimination or excretion, or how to get the drug out of your body. Finally. This is the last video in farmacokinetics. In the next one, we will start talking about pharmacodynamics. Pharmacokinetics has 4 steps: absorption, distribution, metabolism, excretion. How do you excrete? Mostly kidney. But it's not just urine. It could be stool. It could be bile excretion. It could be exhalation, especially for vapors and for inhaled anesthetics, or sometimes sweating. So what's the most common route of elimination? Urine, the kidney. Other routes include the lungs, such as volatile particles, inhaled anesthetics. How about stool? Some drugs are excreted by stool. How about bile? Some drugs are excreted via bile, especially if you are a large molecule. And the biliary elimination system has different pathways for different chemicals. If you're an anion, I have a path for you. If you're neutral, I have a different path for you. If you're a cation, I have a third path for you. Anions include glucuronide conjugates. This was the drug after glucuronidation, as we have discussed in the last video. And these include also oxacillin, cloxacillin, decloxacillin, and nafacillin. We call these the anti-staphylococcal penicillins. They are penicillins that target the bacteria known as Staph aureus. Neutral, such as wabane, which is part of digitalis. Digitalis, the famous heart medication, is not just one drug, it's a family of drugs. And this digitalis family has 3 drugs: digoxin, digitoxin, and wabane. How about the positive charges? Vicuronium, tubicurarine, anything that has curare in it. These are the different routes of elimination. But what's the most common one? The kidney. Tons of drugs end up in the kidney, and that's why many of them can damage the kidney, causing acute tubular necrosis or renal tubular acidosis. Acute tubular necrosis causes hagma, but renal tubular acidosis causes nagma. More on that in the acid-base course on my website. If you watched my YouTube video about the lipid-lowering agents, we have talked about bile acid sequestrants or bile acid resins, such as cholestyramine. What does it do? It traps some molecules here so that they have nowhere to go except the stool. That's how you sequester something and trap something and imprison something in the gut so that it ends up in the feces species. If I'm taking cholestyramine, the bile acids and bile salts are not allowed to go back to the liver in the enterohepatic circulation because bile acid sequestrants will block this. And when the circulation is blocked, I cannot circulate. I'm trapped in the stool. This is an example of elimination. Elimination half-life, or simply half-life, or T half. What is this? Is this an amount? Is this a concentration? Is this a volume? Shut up. It's the time needed to eliminate half of a given amount or of a given dose of a drug. Let's say I gave you 100 milligrams of this drug. The time it takes you to make this 100 milligram becomes 50 milligrams is your half-life. Let's say I gave you the 100 milligrams of the drug and I waited for 2 hours. And in 2 hours, you reduced the amount of drug in your body from 100 to 50. Then your half-life is the 2 hours. Put differently, the half-life is the time needed to reduce the plasma level of a drug to 50% of its original value. I couldn't agree more. Example 1. I gave you 100 milligrams. I waited for 2 hours. This 100 became 50 milligrams in 2 hours. So what's the half-life here? 2 hours. Imagine a different scenario. I gave you 50 milligrams of another drug. I waited for 2 hours and you reduced it from 50 to 25. What's the half-life? Also 2 hours. Now let's talk about the elimination curve. It's a mathematical graph used to estimate, not to measure. We're estimating. We are hypothesizing. We are postulating what? C0. What the flip is that? It's the plasma concentration of the drug at time 0 in the beginning. Remember when we talked about the volume of distribution? Yeah, amount equals volume times concentration. Therefore, concentration is amount over volume. Therefore, volume is amount over concentration. What kind of concentration? C0, the concentration of the drug in the plasma at time 0 in the beginning. This is the exact same C0 that we will discuss right now. Remember, C0 is not measured, it is estimated from a graph. What's the difference between measuring and estimating? Let me explain. Suppose that you have an exam. The highest score or the full mark on that exam is 100 points. Okay, you took that exam 3 times. In the first attempt, you scored 30 points. Good job. In the second exam, you scored something like 60 points. And on the third exam, you scored something like 90 points. All of these are actual results from real life. They are measured. They are not estimated. The question is, what's going to happen to your score on the 4th attempt? I have no idea. All I can do is estimate by extending a straight line like this, and I can guess, oh, you're probably gonna get the highest score. You're probably gonna reach the 100. But is this a fact or is this an estimate? It's an estimate. You have not taken the 4th exam yet. I am hypothesizing based on extending the straight line on the stupid graph. This is what estimate means. The same concept applies for the famous C0. It's not measured, it is estimated. There's the elimination graph or the elimination curve for you, with time on the x-axis and the log of the plasma concentration of the drug on the y-axis, where the flip is C0. Just hold your horses. Let me just ask you a question. 10 power 0 is what? 1. 10 to the power of 1 equals 10. 10 to the power of 2 equals 100. Okay, so when you look at this y-axis, it's gonna look weird. It jumps from 1 to 10 to 100. So don't be shocked. That's the point of a log. In the good old days with no log, you go like this: 0, 10, 20, 30, 40, 50, 60, etc. But when you have a log, 1 is here. When you go up, it becomes 10, 100. What the flip? And then when you go down, 0.1, it's 0.01. This is the log. This is the exponential stuff. Why is that, medicosis? Easy. 10 times 1 is 10. 10 times 2 is 20. 10 times 3, 30. 10 times 4, 40. All the way until reach 100. But here we're not talking 10 times 1. We're talking 10 power 1. Big difference. So we start here. 10 power 0 is 1. We put it here. 10 power 1 is 10. 10 power 2 is 100. 10 power negative 1 is 0.1. 10 power negative 2 is 0.01. This is why it looks different. So when you first take the drug and it gets absorbed, it is here, baby, 100. Oh, perfect. Okay, this is the maximum. This is the peak. And then you start distributing the drug. As you distribute it, you're giving it more to tissue and away from the plasma. What's going to happen to the concentration in the plasma? It's going to start dropping. All of this is called distribution phase. After this, you go to the elimination phase. Remember, distribution was the rapid phase. Metabolism elimination was the slow phase. Rapid decline, slow decline. Decline in what? In the plasma concentration of the drug. Don't forget the log. But hey, medicosis, where is C0? It is here. By continuing and extending the straight line backwards until you reach time 0, right here, you get the C0. So from this graph, C0 equals 10. Yes, 10 what? Milligrams per liter. Thank you. This is the plasma concentration of this drug at time 0. It's an estimate. It's an extrapolation from the elimination curve. That was deep. Quiz time. From the graph down here, if the dose of the drug given was 300 milligrams, please calculate the volume of distribution of that drug. Now pause. You know that amount equals volume times concentration. Therefore, volume equals amount over concentration. What's the amount? The dose of the drug given, the 300 milligrams. What's the concentration? The C0, the plasma concentration of the drug at time 0. Where do I find it? From the graph. Extend the line. Oh, it's about 10. You just put 10. 10 of what? 10 milligrams per liter. 300 milligrams over 10 milligrams per liter. Milligram is going to cancel the milligram. The liter is the denominator of the denominator. It's going to become a numerator, and the answer is going to be 30 liters. This is your volume of distribution. This is the playground available in front of the drug, tissue-wise, so that the drug can get distributed to that tissue if it wishes. Elimination, elimination, elimination. It has two patterns: zero-order elimination and first-order elimination. Zero-order elimination is called saturation kinetics. Why? Because it only happens when all of your carriers and receptors are saturated. Oh, I got it. It's like rush hours. Exactly. Bingo. But if you're not saturated, i.e., most of the time you're playing here, first order elimination or exponential kinetics, most of the drugs are here. But if you give me the drug in a very high dose, in a very toxic dose, such as toxicology cases, intoxication cases, then I've saturated all of the first order and I will start playing with the zero order. Linear growth is like this. Exponential growth is like this. Putting your money under the mattress is like this. Choosing a good investment and sticking with it for decades is like this. Do you remember the traffic pattern and the congestion in a major city during rush hours? It's an exponential growth where a tiny increase in the numbers of cars in the road will give you a huge increase in the travel time and in the congestion. Linear is also known as arithmetic. Exponential is also known as geometrical. Hashtag nonlinearity. Example of the exponential growth is a guy named Warren Buffett. Right now, he's about 91 years old. His net worth, his wealth, is $109 billion. But he did not reach his first million until the age of 30. He was still here, even though it was like a third of his life. But after this, there is some exponential growth. I do not give investment advice on this channel. You can do whatever the flip you want to do with your money. Hey medicoses, do we see the exponential growth in medicine? Sure. Your risk of osteoarthritis starts as linear when you are young and tender. But after this, it gets exponentially bad. The risk of getting osteoarthritis as you hit 80 or 90 is super high. So elimination is either zero order or first order. To understand them, zero order is like donating $10 every year. Every year, I donate 10. The next year, I donate 10. The third year, I also donate $10. But first order elimination is like donating half your wealth every year. So in 2020, I'll donate half of my wealth. And then in 2021, I will donate half of the remaining half, etc. In zero order, a constant amount is donated every year. But in first order, look at this, first half, a constant fraction is donated every year. Not a constant amount, a constant percentage. Let's talk about zero order elimination or saturation kinetics. A constant amount, not percentage amount, is being eliminated per unit time. Look at this. I gave you 80 milligrams of a certain medication. In 4 hours, you lost and eliminated 10 milligrams, so you end up with 70. I waited another 4 hours, you eliminated another 10 milligrams, and you became 60. I waited another 4 hours, you eliminated 10 milligrams, and became 50. A constant amount, 10 milligrams, is being eliminated per unit time, 4 hours. So when you had 80 milligrams in your body, you eliminated 10 milligrams every 4 hours. Also, when the amount of drug in your body was just 50 milligrams, you also eliminated 10 milligrams every 4 hours. In other words, the rate of elimination, 10 milligrams every 4 hours, is independent of the plasma concentration. Whether it's 80 milligrams, whether it's 40 milligrams, you're always eliminating 10 milligrams per hour. The rate of elimination is independent. Let's try to look at the half-life. What's the half-life or the elimination half-life? It's the time needed to get rid of 50% of the drug. So let's look at 80. And 50% of 80 is 40. In order for you to go from 80 to 40, it took us how many hours? 4 plus 4 plus 4 plus 4. It took me 16 freaking hours for the first half-life. But then, look at the second half-life. In order for you to go from 40 to 20, How long did I have to wait? Only 8 hours. Let's continue. Here are 20 milligrams. And then, how long did I have to wait for them to become half? I had to wait 4 hours. So the half-life was 16 hours, and then 8 hours, and then 4 hours. So the half-life is not fixed. The half-life is variable in zero-order elimination kinetics. Does this zero order occur in most cases? No, most cases are first order. Zero order is only for intoxication cases. When your enzymes and transporters are saturated, this is where you stop being first order and you start going to the zero order. Zero order is ugly, by the way. Why? Because the rate of elimination is independent of plasma concentration. What does that mean? Suppose that I give you just 10 milligrams of a drug. Okay, I'll have to wait 4 hours until you can get 10 milligrams out. Okay, but if I give you a very high dose, like a toxic dose, something like 8,000 milligrams, I will still have to wait the same amount of time, 4 hours, to get only 10 milligrams in, which is nothing. That's why toxicity is very dangerous here, because if you start with 8,000, it's going to take you a very long time until you get the drug out of your body. You can't yell at your body, "Hey body, I took too much, please get a lot of drug out of my body quickly." Oops, sorry, I can't. We're saturated. We're full. Conversely, a small increase in the dose, for example, from 80 milligrams to like 120, which might not sound like much, is very huge. Why? Because you will have to wait an extra 16 hours until the drug is eliminated. Because after 4 hours, the 120 will become 110. After another 4 hours, 100. After another 4 hours, 90. After another 4 hours, 80. So, just by increasing the dose from 80 milligrams to 120 milligrams, which a doofus doctor might not consider as a big deal, could be a huge deal because you'll have to wait an extra 16 hours to get the drug out of the body. That's why zero-order elimination is dangerous when everything is saturated. And this happens during elimination of aspirin when given at a very high dose. This is aspirin intoxication or aspirin overdose. It happens with ethanol at high doses and phenytoin at high doses. Remember, zero-order elimination is ugly. It is the exception to the rule. But what is the rule? The rule is the first-order elimination. Most drugs follow the first-order elimination, except, of course, at high toxic doses. First-order elimination, a constant fraction, a constant percentage of the drug is eliminated per unit time. Look at this, 80 milligrams. Okay, give me 4 hours and I will half them to 40 milligrams. Give me another 4 hours, I will not just get rid of 10 milligrams or the same constant amount. No, every time you wait for me, 4 hours, I will decrease this amount to half of the original one. So, wait 4 hours becomes 20. Wait 4 hours becomes 10. Wait 4 hours becomes 5. Wait 4 hours becomes 2.5. What if I started with 160 milligrams? You will have to wait the same 4 hours, and I will decrease this by half. A constant percentage is being eliminated per unit time. The rate of elimination is dependent and directly proportional to the plasma level of the drug. Sure, look at this. Imagine that I started with a very low dose, 5 milligrams. Okay, look how much we lost after 4 hours. Only 2.5 milligrams. But if we start with a high dose, 160 milligrams, look how much we eliminated in the same 4 hours. 80 milligrams were eliminated. Wow, that's a big difference. So let's try to calculate the elimination rate. Anytime you hear the rate, we know that we are dividing by time. So here, when we went from 80 milligrams to 40 milligrams, we lost 40 milligrams in 4 hours. 40 milligrams over 4 hours is an elimination rate of 10 milligrams per hour. Remember this. Next, let's do the same thing when we decrease from 40 to 20. Okay, 40 to 20, I lost 20 milligrams in 4 hours. 20 over 4 is 5 milligrams per hour. You see this? Here the elimination rate was 10 milligrams per hour, but here it's 5 milligrams per hour. The rate of elimination is dependent and directly proportional to the plasma level. The higher the plasma concentration, the higher the rate of elimination. This was not the case in zero-order kinetics, because in zero-order kinetics, the rate of elimination was independent of the plasma level of the drug. Whether you started with high dose, low dose, I didn't care. I excreted 10 milligrams every 4 hours, so the rate did not change. But here the rate does change depending on the original dose or the original plasma level concentration of the drug. The higher the amount, the higher the dose, the more rapid the elimination. In this case, can we get the half-life? Sure, what's the half-life? The amount of time that we have to wait until the amount of drug decreases by half. So from 160 to 80, I waited 4 hours. So the T-half here is 4 hours. From 80 to 40, I waited 4 hours. From 40 to 20, 4 hours. The T-half is always 4 in this example, so the T-half here is constant. Contrast that with the zero-order elimination, the T-half was variable. But in first order, T-half is constant. What do you mean by constant? It doesn't change, and it does not depend on anything. It does not depend on the dose of the drug. Whether you started with high dose or low dose, you will have to wait the same amount of time before I can decrease the drug to half of its original dose. Most of the drugs in pharmacology are first order, except in very high doses. In very high doses, when you saturated everything, you will start acting crazy like zero order, which is dangerous. Quiz time. Please choose the correct answer. Which of the following is zero order kinetics? Which one is first order kinetics? Put differently, which one is saturation kinetics and which one is exponential kinetics? Pause. The linear decay is zero-order elimination, also known as saturation kinetics. The exponential decay is first-order elimination, also known as exponential elimination or exponential kinetics. A constant amount is getting lost every unit time. A constant fraction, a constant percentage is being eliminated per unit time. Big difference. The half-life is variable. The half-life is constant. The rate of elimination is independent of the original plasma drug concentration. But here, the rate of elimination is dependent and directly proportional to the original plasma drug concentration. The rate of elimination does not change. Here, the rate of elimination does change. The higher the original dose, the faster the elimination. Look at the decline from here to here. Super fast is very steep. And look at the decline from here to here. Not as steep. The higher the dose, the more steep, the more rapid the elimination. Pause and review. Rest and digest. Please note, look at the y-axis here. It has concentration, it has concentration. There is no log here. It doesn't exist. Just pure old concentration. Pharmacologists noticed that it is very hard to do math on exponential decay, especially when we're talking to doctors, pharmacists, nurses, where the only reason these doofuses went to the healthcare field is that they suck at math. They are not mathematicians or engineers. So let's make it simple for them. This linear graph is easy to deal with and calculate and estimate, but this exponential is weird. Let's convert the exponential into linear. How the flippy do you do that? By adding a log to the concentration. So instead of pure concentration here, we'll make it log concentration. And we will change it into something called the semi-logarithmic plot. Why are we doing this? In order to change the exponential graph into a linear graph. Do I need to do this modification for the zero order? Shut up. This is already linear. Don't touch it. Leave it alone. If it ain't broken, don't fix it. It's already linear. Don't touch it. We will only do this modification on this first order elimination graph because it's exponential. We will modify it by adding a log to the y-axis to convert it from exponential to linear. And sure enough, when we modified only the first order elimination graph, it went from looking like this, with just concentration here, to looking like this, linear, with log concentration on the y-axis. In a nutshell, the log function turned the exponential decay into linear decay. You don't believe me? You can crunch the numbers. On this graph, 80 was here, 40 is half of it, 20 is half of it, 10 is half of it. Let's add log. What is the log of 10? Just 1. What is the log of 20? About 1.3. What's the log of 40? 1.6. The log of 80 is 1.9. Oh, it went from exponential to linear real quick. Do I need to add a log to the zero order kinetics? No, there is no need to try log here because it's already linear. We only modify the exponential. And this is a crazy exam trick because you only have 3 graphs that can show up on the exam. 1 is exponential, 2 are linear, but there is a big difference. In this linear, look at the y-axis, only concentration. But in this linear, look at the y-axis, log concentration. So when you look at the graph and it's exponential decay like this, you don't even have to think. It's always going to be first order elimination. Okay, got you. But if you look at the graph and it's linear decay, stop and think. Look at the y-axis. If it's just good old concentration, this is zero order elimination. But if this has been modified to log concentration, this is the first order elimination as well. Zero order elimination has 1 shape. First order elimination has 2 shapes depending on who is on the y-axis. Pause and review. There is a great mnemonic for this. The log function is going to make the first order linear. Get a piece of paper, draw the 3 possibilities. Otherwise, there is no hope for you on the exam. This area is very confusing to students. And to me, to be honest. On my exam day, I look at the graph. Okay, something is going down. There is time on the x-axis and there is some kind of plasma concentration on the y-axis. If it's an exponential decay, it's first order elimination. I don't even have to think. But if it's a linear graph, I gotta pause and think. Look at the y-axis. If it's just concentration, this is zero order elimination graph. If it's a log concentration, this is a first order because the log function makes the first order linear instead of exponential. That's the modification. This is what you call the semi-logarithmic plot. I feel like I'm describing a mystery novel. Let's do it again. In order to determine if the graph is zero order or first order, I look at the shape of the graph. Exponential decay? Yes? Then it's first order. No, medicosis, it's not an exponential decay. It is linear decay. Then you gotta stop and think. Look at the y-axis. I see only concentration. It is zero order elimination. I see log concentration. It is first order elimination. The log function makes the first order linear. Quiz time. What is this? Pause. Let's talk about that. I see concentration here, I see time here, I see a graph going down. It's a decay. Is it exponential? No, it is linear. Therefore, I gotta stop and think. What's here? Only concentration. This is zero order elimination kinetics, also known as saturation kinetics, where you have a constant amount of drug eliminated per unit time. The rate of elimination is independent of the original plasma concentration, and the half-life is variable. And this is toxicology land. Hashtag zero order kinetics. Here's a side note. Zero order kinetics is extremistan in extreme circumstances where you have toxicology and toxicity. But first order elimination is mediocristan. Most drugs are first order. Zero order, extremistan. First order, mediocristan. Quiz time. From this graph, please calculate C0 and the half-life. Please pause.
Easy, medicosis. C0 is the plasma concentration at 0 time. So there's 0 time. Let me go here to see the plasma concentration. Oh, medicosis, it is 8.
Shut up. Look at the y-axis carefully. This is concentration, but it's multiplied by 10 to the power of 2. It's multiplied by 100. Take that 8, multiply it by 100. What do you get? 800. 800 what? Look at the axis. Nanogram per milliliter. Next, what's the half-life? Well, the half-life is the time needed to decrease the amount of the drug by half.
Let's do it. So let me take this one, which is 800. Okay. 800, for it to decrease to half, it has to go from 800 to 400. That's true. Okay. All right. When it was 800, what was the time? 0. And when it became 400, what was the time? 90 minutes. So what's the half-life or the time needed to decrease the drug amount into half of the original amount? Oh, it's 90 minutes. Sure. So it's 90 minutes here. But can we double check? Let's do it. How about from 400 to 200? Oh, that also requires a half-life. When it was 400, it was 90. And then when it became 200, it is 180. Between 90 and 180, how much time has elapsed? Also 90 minutes. So I'm pretty sure that this is the correct answer. And sure enough, good job. A new concept, KEL. What is K? Constant. And what is EL? Elimination. The constant of elimination. How do I get this from the graph? It is the slope of the linear decay. Ooh. And if you remember the good old day of math, how did we calculate slope? It's the tan of the theta. It's the tan of the angle. All right, but I cannot give you the angle. I have no idea if this is 45 degrees, 40 degrees, 35 degrees. I cannot do it. So do it the other way. Delta y over delta x. The change in the y-axis over the change on the x-axis. Okay. For example, let's go from 400 to 200 on the y-axis and from 90 to 180 on the x-axis. 400 minus 200 over 90 minus 180. 400 minus 200 is just 200. 90 minus 180 is negative 90. Do the math, you get the slope as negative 2.2 nanograms per ml per minute. Why is the slope negative? Because we're going down. We're not going up. If you're going up like this, you will have a positive slope. But if you're going down like this, you'll have a negative slope. Quiz time. Which drug has a faster elimination rate? Is it drug A or drug B? That's the first question. The second question, which drug has a shorter half-life? Is it A or B? Now pause. Let's do this. When it comes to the first question, which one has a faster elimination rate? Remember, the steeper the slope, the faster the decay. Between A and B, which one is steeper? B is more steep, A is more flat. The steeper the slope, the faster the decay. Therefore, the answer here is B. B has a faster decline, a faster decay, a faster elimination rate. Second question, which drug has a shorter half-life? Let's do it on the graph. Let's get the half-life for graph A, the blue one. So let's use a blue color. In order for me to get from 8 to 4, okay, I have to go from 0, which happens at 8, and then 4, go until you intersect. All right, let's call it 90. So the half-life of A is about 90 minutes. Let me write it down here. How about the half-life for B? When I went from 8 to 4 B, the concentration of 8 happened at time 0. The concentration of 4 happened at, way less than 90. Let's just call it 40 minutes. Now, which one had a shorter half-life? The shorter one is B. Hey, medicoses, are you trying to say that the faster the elimination rate, the shorter the half-life? That's true, which means that there is an inverse correlation between the elimination rate and the half-life. That's exactly right. The faster your elimination, the shorter the half-life is, because you are better at it. You get the drug out of your body faster. You eliminate it quicker in a shorter period of time. Here's a very important rule. The steeper the slope, the faster the decay. So if this blue line like this is A, and I draw another line here and call it B, which one is steeper? B is steeper. The steeper the slope, the faster the decay, which means B has a higher rate of elimination or rate of decay than A. The rate of elimination for B is faster and its half-life is shorter than A. Don't forget that the half-life is a time and is to be found on the x-axis. The steeper the slope, the faster the decay, and the shorter the half-life. Between T-half and K elimination is an inverse correlation. The faster the elimination, the shorter the half-life. When K elimination goes up, the half-life is gonna go down. It gets shorter because you do it faster. If I get to work faster, I have decreased the time. So if T-half is inversely proportional to K elimination, and I want to remove this proportional sign and put an equal, I have to multiply this by a constant. So T-half equals constant times whatever was here. Okay, what's that constant? The constant, mathematician have told us that it's about 0.7. So T half is 0.7 over K elimination. If your textbook is super sophisticated, they use 0.693, which is about 0.7. Who cares? The constant of elimination is the sum of two other constants, the constant of metabolism and the constant of excretion, because in order to get the drug out of your body, you have to metabolize it first and then you have to excrete it. Liver followed by kidney, and the sum is called the constant of elimination, total elimination. Quiz time. Assume that we have a drug, let's call it X, whose elimination constant is 0.01 hour power negative 1. Please calculate the elimination half-life. Easy. Use the equation T half equals 0.7 over the K elimination. Therefore, T half equals 0.7 over 0.01. Hour to the negative 1 here can go up and become just hour without the negative 1. Get the reciprocal. 0.7 over 0.01 equals 70. 70 what? Hours. That's your half-life, aka elimination half-life, which is the time needed to have the original amount of the drug. Another quiz time. Assume that we have a drug, let's call it Y, whose metabolic rate constant is 0.02 and whose excretion rate constant is 0.01. Please calculate the half-life. Okay, medicoses, I know that half-life equals 0.7 over K elimination, but I don't have K elimination. Yes, they didn't give you K elimination, but they gave you Km for metabolism and Kex for excretion. Just add these two doofuses together, you get the K elimination, which is 0.03 hour power negative 1, and then 0.7 over the 0.03, the hour that was here, because it's power negative 1, should go upstairs. You do the math, it's 23.3 hours. That's your answer. Next is the concept of clearance. What is clearance? Clearance is it a time? No. Is it a concentration? No. Is it an amount? No. It's a volume. The volume of what? Of the drug? Nope. The volume of plasma that gets cleared from the drug, that gets cleared of the drug. Suppose that we have an amount of plasma here. Let's call it just 1 liter. Okay? I have 1 liter of plasma there. And this plasma is dirty. It has some drugs in it. And then here, I ended up filtering the plasma, cleaning the plasma, and I gave you clean plasma without any drugs. How long did it take you to clean my 1 liter of plasma? Of any drugs, it took me about 1 hour. So, 1 liter of plasma has been cleaned in 1 hour. Therefore, the clearance is 1 liter per hour. It's the volume of plasma that gets cleared of the amount of drug per unit time, usually per minute. Where's the dirty drug going? To the pee, to the urine or bile. If the drug X is not bound to plasma proteins, if that drug is freely filtered and then neither reabsorbed nor secreted, its clearance will equal the GFR, and we learned this from physiology. What's the normal GFR? About 125 ml per minute. Volume per time. Volume per time. What's the normal filtration rate or GFR? 125 ml per minute. What's the normal tubular secretion rate? 660 ml per minute. As you know, what is secretion? Secretion is when you take something from the blood and dump it onto the tubule. Dump it into the urine. What is clearance? Clearance is not referring to the drug. It's referring to the plasma. The volume of plasma that I will clean for you. I will clean it of any drugs. Here is 1 liter of blood. It is dirty. It has drugs in it. Okay. Give me some time. I will clear it and clean it and give you some clean blood 1 minute later. Therefore, what's the clearance here? 1 liter has been cleaned in 1 minute. So it's 1 liter per minute. That's your clearance. We have 2 types of clearance. Renal clearance, where the drug is going to the urine, and metabolic clearance, where the drug is excreted in the bile. 1 milliliter of plasma entered here. It was dirty. And then I ended up here with 1 milliliter of plasma that has been cleared in 1 minute. So what's the clearance? It's 1 milliliter per minute. Quiz time. I gave you 1 liter of dirty blood, dirty plasma. It has drugs in it, about 800 milligrams. The drug concentration is 800 milligrams per liter. And after 1 minute, it was cleared. Can you calculate the clearance?
Oh yeah, medicosis, it's 800 per minute.
Shut up! The clearance is not referring to the drug. It's referring to the volume of the plasma. Therefore, the clearance is 1 liter per minute. Clearance is the volume of plasma that got cleaned and cleared of the drug per minute. If the concentration of sodium in the test tube is 2 grams per liter and I have 3 liters of water, what's the amount of sodium in the entire test tube? Amount equals concentration times volume equals 6 grams. This is called what? The Fick principle. Pause and review. The clearance is referring to the volume of plasma that gets cleaned per unit time. Pause and review. Why do we care about plasma clearance so much? Because we can use it to estimate the GFR.
How come, medicosis?
I will inject you with a substance that you cannot metabolize, something that you have never seen before. Inulin.
Okay.
I give you inulin. Nice. The amount of inulin is here, and since you cannot deal with it, the amount of inulin here in the urine is going to be the exact same, right? So the amount of inulin going in equals the amount of inulin coming out. Perfect. And since amount equals volume times concentration, therefore volume times concentration of inulin in the plasma going in equals volume times the concentration of inulin in the urine coming out. We should always begin with the end in mind. Amount of inulin going in equals amount of inulin coming out. Plasma's here, urine is here. Volume times concentration of inulin in the plasma equals volume times concentration of inulin in the urine. So, plasma volume times plasma concentration equals urine volume times urine concentration. Begin with the end in mind. What are you trying to achieve? I'm trying to measure the GFR. Oh, GFR is the same as clearance of the plasma when you are freely filtered, not reabsorbed, and not secreted. So that's going to be your GFR. Do some algebra. PV, which is the GFR, is going to equal UV times UC over PC. What is that? The volume of the urine or the urine flow rate. What is this? The concentration of inulin in the urine. And what's that? Concentration of inulin in the plasma. Do the math. This is going to equal 125 mLs per minute. This is how you can measure GFR in a real patient. PV is the volume of the plasma, is the same as inulin clearance, is the same as GFR, and normally the GFR is 125 what? Volume per minute. It's the volume of plasma that gets cleared of inulin per minute. So your GFR or your plasma clearance equals VOOP. V times U over P. VOOP. What's the V? Urine volume. What's the U? Urine concentration of inulin. So the concentration of inulin in the urine. What is PC? Concentration of inulin in the plasma. VOOP. Never ever forget the VOOP. VOOP equals GFR. VOOP equals renal plasma clearance. Not to be confused with H&M clearance. Quiz time. You're trying to measure the GFR. You injected inulin intravenously. The urine volume was 0.6 liters per hour. Urine concentration of inulin was 100 milligrams per ml. Plasma concentration was 20. Can we get the GFR? Please pause. First of all, you see this liter per hour, but you see this milligram per ml, so we gotta convert this liter into ml. Also, we gotta convert hour into minute. So this is 600 mLs per hour, and since we have 60 minutes in an hour, it's about 10 mLs per minute. What's that? That's the urine volume, that's the V. So the V is 10 mLs per minute. And then what's the U? The U is 100 milligrams per ml, and the plasma concentration of inulin is 20 milligrams per ml. Do the math, and the answer is 50 mLs per minute. That's your GFR. That is your renal plasma clearance. This is the volume of plasma that gets cleared of inulin per minute. Quiz time. Raj has a GFR of 100 ml per minute. Raj took a drug. 50% of that drug is bound to plasma protein, the other 50% is not bound. Assuming no reabsorption, no secretion, please calculate the renal clearance of the drug that Raj took.
The renal clearance of the drug is the same as GFR, is the same as VUP.
But hey, medico says they already told me that the GFR of Raj kidney is 100 ml per minute.
That's true. But don't forget, 50% of that drug will never see the kidney. It will never get filtered. So we only deal with that 50%. So out of that 100 ml per minute, the actual filtration and clearance of that drug is going to be half of the 100, just 50 ml per minute. Renal clearance equals VUP, V times U over P. But total body clearance is the volume of plasma. No, plasma is not the only thing in your entire body. This is the volume of distribution, the entire playground that's available in front of the drug. That's the volume. How fast do you do it? I do it per time. So that's the elimination rate. How much times how fast? This is very similar to the cardiac output of your heart. How much times how fast? How much blood are you pumping with each pump? Stroke volume. Times how many pumps per minute? Heart rate. Same thing here. Total body clearance is the volume of distribution times the elimination rate. Don't forget that T half is 0.7 over the K elimination, and therefore the K elimination is 0.7 over the half-life. Clearance, this is the total body clearance, is volume of distribution, true, times K elimination. And since K elimination is 0.7 over T half, I can do it like this. More equations. Amount equals volume times concentration. Therefore, concentration is the amount over the volume. What's the amount? The dose of the drug. What's the volume? The volume of distribution. Where do I get C0 from? It's an extrapolated point on the elimination curve. You get it by extending the straight line backwards. This is total body clearance. This is just renal plasma clearance. Total body clearance is of course more inclusive and more comprehensive than the renal clearance. Renal clearance is just talking about the renal plasma clearance. Is plasma the only game in town? Not true. You also have to account for the tissue. Total body clearance is here. It's the volume of distribution times the K elimination or the elimination rate. But the renal plasma clearance is good old VUP. Quiz time. Suppose that a drug has a distribution volume of 200 liters and an elimination rate of 0.1 hour power negative 1. What's the total body clearance? I already know that the volume of distribution is 200 and the K elimination is 0.1. Let's do the math. Total body clearance equals volume of distribution times the K elimination. So you get 20 liters per hour. We gotta convert liters per hour to ml per minute. Do the math. Here is the answer. Quiz time. Suppose that a drug has a urine concentration of this in a 3000 ml urine collected per hour. Meanwhile, the plasma concentration of the same drug was 0.15 milligrams per ml. Which of the following statements better describe this drug? Pause. If you look at the question stem carefully, they gave you the VUP. Therefore, they want you to calculate renal plasma clearance. When I calculated the renal plasma clearance, the answer was 667.67. What? ml per minute. Do you remember the normal filtration rate? 125. This assumes that the drug is freely filtered, not reabsorbed, and not secreted. Is this close to this? Not even close. So this drug is not freely filtered, neither reabsorbed nor secreted. That's not true. So B is out. How about A? Not filtered at all. Well, if all of this is coming clean from the urine, the drug was filtered for sure. So A is out. Look at this number and look at the secretion rate, which is very similar. This drug is filtered and then secreted. It was not reabsorbed, because if it were reabsorbed, you will find that the answer is smaller than the 125 GFR. But the answer was greater than the GFR, which means someone is dumping more drug onto the kidney tubule. This is called secretion. Farmacokinetics. Elimination is either zero order versus first order. Zero order only happens when everything is saturated. This is for toxic doses. But first order is most medication. This is mediocre stan. This is extreme stan. Zero order, T half is variable. First order, the half-life is constant. The elimination rate is the other way around. When something gets into the kidney's tubule, it's called filtration. Reabsorption is when it leaves the kidney tubule. When it leaves the urine, it goes to the blood. Secretion is when it leaves the blood and goes to the urine.
Therefore, what's the urinary excretion rate? What you started with minus what you took out plus what you added to the urine. This is what's going to end up in the urine per unit time because it's a rate. Some drugs undergo tubular secretion, which means after they are filtered, we keep dumping more drug into the urine. And this includes aspirin, loop diuretics, thiazide diuretics, penicillins, and cephalosporins, which are antibiotics. How do we secrete these drugs? You need tubular transporters to carry them from here to here. If we need transporters, can someone tamper with these transporters and cause problems? Sure. Example, penicillin wants to get excreted in the kidney and secreted in the kidney, but it requires a transporter. There is another drug called probenecid, which tampers with the penicillin transporter. Probenecid is going to go and inhibit the transporter of penicillin. Therefore, penicillin is not going to get secreted into the urine. More penicillin is going to end up in your blood, prolonging its half-life and increasing penicillin level in the blood and toxicity. This probenecid inhibited the secretion of penicillin, cephalosporin, imipenem. However, it increased the secretion of uric acid. Wow, because uric acid has a separate tubular transporter. Statisticians always tell us, garbage in, garbage out. If the input is garbage, the output is going to be garbage too. Just because you have data, it doesn't mean they are good data. They could be rubbish. Pharmacology has the same concept. It's called the steady state. When the rate of the drug coming in is the same as the rate of the drug going out. This is equilibrium, the state of being steady in the blood. What's the time needed until I reach this beautiful state of steady, the state of equilibrium? This time is only dependent on the half-life. That's it. It's not dependent on the dose of the drug. Whether you started me on 100 milligrams, 200 milligrams, or 300 milligrams, this does not affect the time needed to reach the steady state. It's also not dependent on how often did you give me the drug. Did you give it to me once a day, twice a day, 3 times a day? This does not affect the steady state. What is that plateau principle? This principle, that they are only dependent on half-lives. About 5 half-lives will take you to the promised land of the steady state. That's your plateau. Time is here, concentration is here. The doctor gave me a drug. Okay, 100, bro, I love it. 100 micrograms per ml. And that was the first dose. After this, half-life, and I'm back here. The doctor gave me another dose. Went up to 150. And then I'm eliminating the drug. A third dose, and I'm eliminating. A fourth dose, I'm eliminating. Fifth dose, I'm eliminating. I went to 194 out of the maximum of 200. That's amazing. And then 197. And then another dose. And then another dose. And this is your plateau. You will never get better than this. This graph is talking about that the drug was given by IV bolus multiple times at intervals that happen to equal the half-life of the drug. If the half-life of the drug was 1 hour, I kept giving you a new dose every single hour. This graph has a maximum or crest or peak or zenith or top, and this is called C max. C for concentration. What is this SS? Steady state. This is the maximum steady state concentration. It also has a bottom and it has an average, and this is called the average steady state concentration. Question: how many half-lives were needed to achieve the mathematical steady state? Now pause. What's the mathematical steady state? The utmost point, which is the 200. Let's count this. First dose is here. Second dose is here. Third dose is here. Fourth dose is here. Fifth dose is here. 6, 7, 8th dose took me to the zenith, took me to the top. So the answer is 8 or more than 7 half-lives because I administered the drug every half-life. This is for the math nerd. But doctors are not math nerds. We're just trying to help flesh and blood human beings in real life. So please calculate the clinical steady state. And the answer is 4 to 5 half-lives. Let me prove it to you. Here's the first dose, and then let me second dose, third dose, fourth dose, fifth dose. Fifth dose is 194. And what's the mathematical one? It was 200. Okay. In real life, do you think the E. coli will say 200 micrograms per ml is gonna kill me, but 194 will not? Oh, shut up.
Clinically, they are the same. So clinically, 5 half-lives is good enough for the patient. Why do you want to give 8 doses when you can achieve the same clinical outcome with just 5 doses? Because you also have to take the side effects into account. Some drugs have high rate of infusion, others have low rate of infusion. As you see, the green line is double the infusion rate of the red line. Quiz time. Which one of these graphs, A or B, reached the steady state earlier? Is it A, is it B, or did they both reach the steady state at the same time? And the answer is C. Both reach the steady state at the same time, because remember, the steady state is only dependent on the half-life. The steady state does not care about the rate of infusion. It does not care about the dosing interval or how often did you give the drug. And it does not care on the original concentration or the original dose. I don't care. I just care about the elimination half-life. And remember, the steady state is a plateau. A is going to plateau here. B is going to plateau in the same moment, which is here. This is where both plateaued. So both reach the steady state the same. We're talking about the time needed to reach the steady state. So the time is read from the x-axis, not from the y-axis. I don't care which one is higher on the y-axis. I only care about the x-axis. Both of them started to flatten at the same time. Here is another question. Which one achieved a higher steady state concentration? Is it A, B, or both? Pause. In the previous question, they were asking about the time it took us to reach the steady state. So you read it from the x-axis. But now they're asking about the steady state concentration. You read it on the y-axis. Of course, the green one has a higher steady state concentration. Yes, they reach the steady state in the same time, but when both of them reach the steady state, A had a higher concentration at that steady state as compared to B. Pharmacology is not hard. You just need to get your head out of your sphincter. Therefore, increasing the infusion rate, instead of infusing you every day once, I will infuse you twice per day, 3 times per day. As you increase the infusion rate, you will not change the time needed to reach the steady state. It will still take you about 5 half-lives to reach the clinical steady state. What increasing the infusion rate does for you is raise the concentration when you reach the steady state. 1 half-life or 1 dose will put you about half of the steady state. 3.3 half-lives or 3.3 doses, assuming that you give a dose every half-life, will put you about 90%. The clinical sweet spot is 4 to 5 half-life, 95%. This is very good for the clinic. It's not good enough for the math nerds because the mathematical is greater than half. But clinically speaking, 4 to 5 half-lives is enough to reach the steady state. Drug is coming in, drug is leaving. In between, there is an equilibrium called the steady state. Rate in, rate out. In physics or math, when you hear the word rate, it means something is divided by time. You'll see time in the denominator. The speed is the rate of change in distance. How about the erythrocyte sedimentation rate? It was the rate. There is time in the denominator. It was the rate of sedimentation. So what's the rate of the drug going in? It's the rate, right? So there is time and there is amount. Time in the denominator, amount in the numerator. How about the rate out? Volume over time. Why amount here but volume here? Easy. Because when I give you a drug, I give you a dose. 100 milligrams, 200 milligrams. This is an amount. It's just milligrams. But who gets rid of the drug? The kidney. And it's always in the urine. And the urine is fluid. So that's a volume. How do I get the steady state concentration? Oh, any concentration is what? Amount over volume, because amount equals volume times concentration. Tell me about the rate of the drug going out. It's volume over time. Where have I heard of this before? The clearance. Thank you. How about the rate in? It's amount over time. And this depends on something called the rate of infusion. Some people write it as K0, some people write it as R0. And then we have other symbols. MD for the maintenance dose, and the TAV, the Greek letter, is for dosing interval. Do I give you the drug once a day, twice a day, 3 times a day, 4 times a day, etc.? Should I give it to you every 1 hour, every 2 hours, every 3 hours? Rate in is amount over time. Rate out is volume over time. What's the steady state concentration? Rate in over rate out. The rate in is amount over time. The rate out is volume over time. Time is going to get cancelled with the time, and then you end up with amount over volume, which makes sense because any concentration is amount over volume. Rate out is just good old clearance, volume over time. Rate in is the rate of infusion. Oh, okay, so it's K0 or R0. And this happens to equal what? The bioavailability of the drug that you're giving. If I'm giving this as an intravenous bolus, then the bioavailability is 100%, which is just 1. So 1 times anything is just this thing. So if you're giving it by IV bolus, you can just remove the F, and it's going to be MD over T. What's the MD? Maintenance dose. What's the T or the TAV? Dosing interval. And what's the steady state concentration? Rate in over rate out. Here is rate out. There are 2 forms of chronic drug dosing. I can give you a drug by IV infusion. Drip, 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 continuous IV administration. Or I can just give you different dosing intervals. This is like an oral drug. Take a drug at 8 a.m. Take the second dose at noon. Take a third dose in the evening. There's multiple dosing. So if you're doing it as just continuous IV infusion, your steady state concentration is what's going in, which is the rate of infusion, don't forget the bioavailability, over coming out, which is the clearance. But what if I'm taking pills orally? And these are separate maintenance doses. So the steady state concentration is the bioavailability of the drug times maintenance dose over the dosing interval. All of this is over what's coming out. Getting in, getting out. What is the loading dose? Well, I'm glad you asked. The loading dose is the single dose that I can give you. And once this dose is distributed, it gives you a concentration that's closer to the concentration at the steady state. Just 1 dose, and instead of like 4 to 5 doses to reach the clinical steady state, yep, the loading dose is just 1 huge dose that gives you an effective concentration. How do I calculate this medicosis? Easy. The loading dose is the dose that you'll give. So is this an amount, volume, or a concentration? It's an amount. Any amount equals volume times concentration. What's the volume? The volume of distribution. What's the concentration? The steady state concentration. Does the bioavailability matter? Of course it matters. If it's an intravenous bolus, you can ignore this because it's just 100%. It's not gonna matter. But if it's an oral drug, of course, if it's 30% bioavailability, this is very different from 70% bioavailability. And don't forget that the bioavailability depends on the route of administration. So the loading dose depends on the bioavailability, which depends on the route of administration. When should I give a loading dose? If a drug has a long half-life, which means in order for me to wait for the clinical steady state, 4 to 5 half-lives, the patient will be dead. So I have to add a loading dose. Or when my patient is super sick and it is known that the efficacy of the drug starts only at the steady state, not before that. So I cannot wait. I have to act quickly and load the patient with a big, humongous, singular dose. Quiz time. Sally has a urinary tract infection caused by an organism resistant to the antibiotic cotrimoxazole. You order ciprofloxacin instead. Hopefully it's gonna work. The volume of distribution for this drug is 40 liters. The clearance is 80 mL per minute. You desire to quickly reach the therapeutic plasma concentration to help Sally. Otherwise, she might die from complications of pyelonephritis or something. And what's the goal? 4 milligrams per liter. The question is, how much ciprofloxacin should you give? This question is asking you about what? You guessed it, the loading dose. It's an amount, which equals volume times concentration. What's the volume? The volume of distribution, 40 liters. What's the concentration? The steady state concentration, which is 4 milligrams per liter. Do the math. You should load Sally with 160 milligrams in a one big, single, huge, humongous dose, which is what we call the loading dose.
Quiz time number 2. Same Sally, same UTI, same drug resistance. You gave ciprofloxacin, volume of distribution is here, clearance is here. What maintenance dose should you give Sally intravenously every 6 hours? This is an IV bolus, not a continuous IV infusion, to reach an average steady state concentration of about 4 milligrams per liter. Please pause. You already know that steady state concentration is the rate going in over the rate coming out. So it's amount over time over volume over time, and therefore concentration is amount over volume. Thank you. What's the rate in? It's the rate of infusion, which equals bioavailability times maintenance dose over the dosing interval. They didn't give us the bioavailability, so we'll just ignore it and we'll assume it's 1 or 100%, and we will not enter it into the equation because I cannot enter a hypothetical number. So it's just maintenance dose over dosing interval. And what's the rate of the drug coming out of her body? That's the clearance. So steady state concentration is MD over TAV over clearance. Do I know the MD? No, they want us to calculate the maintenance dose. Okay. Do I know the TAV? Yes, the TAV is every 6 hours. That's the dosing interval. Do I know the clearance? Yes, I do know the clearance is 80 ml per minute. Do I know the steady state concentration? Yes, it's 40 milligrams per liter. You will need to convert all of these liters to milliliters so that you can solve it. And when you do the math, you'll find that the maintenance dose is 115 milligrams, which means every 6 hours, you need to give Sally an IV bolus dose of ciprofloxacin. How much? 115 milligrams every 6 hours. Why are you doing this? To reach an effective steady state concentration of 4 milligrams per liter to treat her UTI. Here are all the equations that you need. Don't forget, maintenance dose and loading dose are dependent on the bioavailability, which depends on the route of administration. How do I get the loading dose? It's an amount, which equals volume times concentration. But what if the drug is oral? Well, you have to adjust it a little, and it's 1.44 times the steady state concentration times the volume of distribution. Since this is oral, you have to account for the bioavailability. For the pros, let's play with some algebra. You already know that the rate of infusion is the bioavailability times maintenance dose over the dosing interval. And you already know that the steady state concentration is the bioavailability times MD over TAV over clearance. Isn't it true that bioavailability times this, like all of this, scissors, equals CSS times CL? It's absolutely true. And all of this is what? All of this equals the rate of infusion. Therefore, the rate of infusion equals steady state concentration times clearance. And I already know that the total body clearance is what? Volume of distribution times K elimination. Therefore, the rate of infusion equals steady state concentration times volume of distribution times K elimination. I just substituted this for the clearance and I added them here. Quiz time. Read and pause. So as you see here, I have 200 milligrams administered every half-life. What's that? That's the maintenance dose. Administered every half-life, so the TAV or the dosing interval is the same as the half-life. What's the half-life here? 6 hours. Can you calculate the rate of infusion? Sure, the rate of infusion or K0 or R0 equals the bioavailability. Do I have it? Yes, 20% or 0.2 multiplied by the maintenance dose. Do I have it? Yes, it's the 200 milligrams over the TAV, which is the same as the half-life, which is 6 hours. Do the math, it's 6.67 milligrams per hour. And I have already proven to you mathematically that the infusion rate equals the steady state concentration times volume of distribution times the elimination rate. Do I have the rate of infusion? Yes, I do. Do I have the volume of distribution? Yes, I do. Do I have the elimination rate? No, I do not, but I can get it for you. Since half-life is 0.7 over the elimination rate, therefore the elimination rate is 0.7 over the half-life, which is 6 hours. Do the math. So now I know this, I know this, I know this. Can you calculate the concentration in the steady state? I sure can. Let me just tell you that this was a very difficult question. If you answered this correctly,
You deserve a treat. Go eat some low-fat ice cream and then calculate the steady-state concentration of the vanilla. Oh, come on, medicosis. Don't ruin my ice cream. Another quiz time. If the infusion rate of an oral drug is 4.17 milligrams per hour, and the bioavailability is here, the volume of distribution is here, the half-life is here, the drug is administered every half-life, what's the loading dose? The loading dose is an amount. Any amount equals concentration times volume. But notice this is an oral drug. Oh, we have to make the stupid adjustment. 1.44 times steady state concentration times volume of distribution over the bioavailability, which is 0.25. Do I have the volume of distribution? Yes, we do. It is 50. Do I have the bioavailability? Yes, you do. It is 0.25. Do I have the concentration at the steady state? No, we have to calculate this. If I get this, it's over. Remember this, which I've mathematically proven to you? Yeah, therefore steady state concentration is the rate of infusion over volume of distribution times K elimination. Do you have K elimination? No, but I can get it for you. 0.7 over the half-life equals 0.058. And I already know that the volume of distribution is 50 liters and that the rate of infusion is 4.17. Now it is over. 1.44 times 1.44 times 50 over 0.25. Liter is going to go with the liter and you will end up with 415 milligrams. That's the loading dose. You should load your patient with a big single humongous dose of 415. Quiz time. Please pause. The drug is administered every half-life. The maintenance dose is 100 milligram. What's the loading dose? Hey, medicosis, there is not enough information. I can do this. Well, as a medicosis, since I am a pharmacology connoisseur, I can tell you that the loading dose is double the maintenance dose. What the what? As long as the drug is administered every half-life. I don't get it, medicosis. Is this magic or what? How did you do it? It's not magic, it's just math. Let me prove it to you. Remember that the steady state concentration is the bioavailability times maintenance dose over dosing interval all over clearance. Yeah, I know that. Therefore, this equals clearance times the steady state concentration. I already know that. Therefore, maintenance dose times bioavailability equals steady state concentration times clearance times the dosing interval. I get it. Maintenance dose alone is steady state concentration times clearance times TAV over the bioavailability. Easy peasy. The drug is administered every half-life, true? Yeah, so let's remove the TAV and let's put half-life instead. I am with you so far. And you know from experience that clearance is the volume of distribution times K elimination. How much times how fast? Stroke volume, heart rate. Oh, I remember this. But wait, it gets better. You already know that K elimination is 0.7 over T half. True? Yeah. Therefore, clearance is volume of distribution times 0.7 over T half. I'm with you. We will remove the clearance from here and put all of this instead. Alright, so maintenance dose is steady state concentration times volume distribution times 0.7 over T half times the T half. Okay, T half is going to cancel the T half and you will end up with a maintenance dose that equals steady state concentration times volume of distribution times 0.7 over bioavailability. And we'll call this number 1. Okay. Second point, you remember that the loading dose for an oral medication is 1.44 steady state concentration times volume of distribution over bioavailability. Yeah, let's just organize it and call it 2. I'm with you so far. If I want to get a ratio, which is the loading dose over the maintenance dose, I have to put this over this. Yeah, I'm with you. Let's do it. Loading dose over maintenance dose equals the loading doses here over the maintenance doses here. Now notice the magic. Bioavailability is going to get cancelled with bioavailability. Let's remove the volume of distribution with the volume of distribution. Let's eliminate the steady state concentration with the steady state concentration, and you will end up with just 1.44 over 0.7, which is about 2. So the ratio between the loading dose to the maintenance dose is 2 or 2 to 1, which means when you give the drug every half-life, the loading dose is double the maintenance dose. I told you that the maintenance dose is 100. Therefore, the loading dose is 200. And this is the answer. When the drug is given at its half-life intervals, the loading dose is double the maintenance dose. Okay, medicos, but on the exam I might forget, is the loading dose double maintenance dose or is it the other way around? Just remember that the loading dose, L, is larger. Okay, I got it now. So the loading dose is larger than the maintenance dose. It is larger by like double. Rate of infusion could be denoted as K0 or R0. Since amount equals volume times concentration, what is the total amount of drug in my body at any time? It's the volume of distribution times the plasma concentration. Quiz time. Please read and pause. I know the volume of distribution. I know the plasma concentration. Can you give me the amount of the drug in my body? Sure. Volume times concentration. Boom, boom, boom. 50 milligrams. This is the total amount of drug in your body right now. Which takes us to the apotheosis of farmacokinetics, one huge curve that has the entire story. The doctor gave me the drug here, started the infusion, and this is time 0. Okay, the drug kept increasing in my plasma over time. I'm with you. How long did it take you until you reached the clinical steady state? About 5 half-lives. Here we are assuming that the dosing interval is the same as the half-life. The first dose was here, the second dose is here, the third dose is here, the fourth dose is here, fifth dose is here, sixth dose is here. As you see, dose number 5 gives me very close to the steady state. That's good enough for me. Elimination is also 5 half-lives. It takes about 5 half-lives to clinically eliminate the drug. Let's follow it. After first half-life, look at this. I went from here to half. Okay, in the first half-life. Second half-life, third half-life, fourth half-life, the drug is almost non-existent as far as we're clinically concerned. It takes about 5 half-lives to reach the steady state. It also takes about 5 half-lives to clinically eliminate the drug. Non-linearity while going up, non-linearity while going down. It takes 5 half-lives to reach the steady state. It also takes 5 half-lives to completely or almost completely eliminate the drug. Hey medicosis, I have a problem. Propofol. It gets rapidly metabolized outside the liver and it's very slowly distributing. It doesn't go from the blood to tissue well. What should I do? Give it as IV infusion. And 5 half-lives, it's gonna reach the steady state. Another 5 half-lives, it will be eliminated. We're done with farmacokinetics, which was way harder than pharmacodynamics. The rest is a breeze. Congratulations, you have made it to the promised land. Thank you for watching.